Welcome back to the Intent Medical Group podcast, where we explore the science, stories, and innovations shaping the way we live and care for our health. I'm your host, Dr. Sammy Khalili, and I'm truly excited for today's conversation. I have the honor and privilege of welcoming Dr. Asadullah Khan, co-chief of our Neuro-Oncology program at Intent Medical Group. Dr. Khan plays a vital role in advancing brain tumor care across our organization, guiding complex treatment decisions, leading multidisciplinary collaboration, and helping shape the future of neuro-oncology within our system. Not only that, he's one of the most interesting people I know. He's a tremendous amount of fun, and he describes himself as a people's doctor. And I really look forward to our conversation. So let's get into it. Dr. Khan, my good friend, I am beyond excited to have you here today. Honestly, I feel like we've been trying to have this happen for way too long. Yeah,
yes, for a while.
But I can honestly tell you, you're one of the most fun people to talk with anyway on a regular basis. So I can only envision how much the audience will enjoy our conversation.
Well, I hope so.
Well, you are a man full of stories. But before we get to those, what I'd like to know from you, and I think that's what a lot of people enjoy hearing, is, there's so many different parts of medicine that we deal with on a regular basis, and each of us chose a different pathway into it. But everyone, as I've been talking with over time, there's been a very different, some similar, but some very different trajectory in terms of how they got interested in medicine specifically. Mm-hmm. So yours is a little bit different than most. Mm-hmm. Why don't you tell me, not tell me, because I know a little bit about this story, but I think for the audience, they would really enjoy this. Tell us how you got first interested in medicine. What brought you into the field?
Good question. So I'm one of 7 kids in our family. And as far as I could remember, everybody, like when as a kid, people would say like, "Oh, no, you're going to be a doctor." And I did not know anything else, but I'm going to be a doctor. That's all I was thinking about growing up. I mean, I could remember that as when I was like 5 years old, people would say like, "You're going to be a doctor."
And was there something you were specifically doing at the time that was triggering that, or was it wishful thinking on their part, or?
Well, I think one of the thing is, I was friends with everyone. I was very kind. I think that's what they saw too. Like, you're so kind. You're so kind. You're so good to us. Like even like all my uncles. I have 49 uncles, so all of them would be like the same way. Like, you're going to be a doctor. You're very kind. You're very kind. And I was not a naughty kid. I was the good kid. I was the teacher's pet. So I think people saw that I'm going to do something good, hopefully, with my life.
Right.
So I think that. So that's what I had in mind, that, I'm going to be. So I had 2 things in mind that I wanted to be. Being a doctor was one of the first thing. And I also like nature a lot. So planting, growing, farming, stuff like that. That was my other passion. So these are the 2 things. If I was not going to be a doctor, I was going to be a farmer.
Wow. 2 very distinctly
different things.
Very different things. Yeah. And I know we glazed over this part for just a second. How many uncles did you say you have?
So my grandfather married 7 times. So needless to say, we had a big family.
Wow.
So with all those uncles and aunts and everything, there was a lot of people, and we lived together. So the idea was like all these kids and the wives and everybody else, they lived together in one big huge house. And every time they will have a new family, new wife, or new kids being born in it, so they just add another portion to the house. So it was a big house.
You had a village, but as your house, I guess.
Correct.
Yeah.
Yes. So the village was all my cousins or second cousins. I mean, everybody was related to me somehow.
in one way or another. So I guess because of that, you would have. Where were you in the age range of where people were born? Were you one of the first, or were you in the middle, or are you down?
I was one of the last ones.
One of the last
I have
ones.
a younger brother, so I'm the 6th one among the 7 kids we have.
Of your 7, but of your cousins, are you also in the lower end of that, or are you in the higher end of that?
Yeah, so in the cousins, I'm a little bit towards the lower end. My father was third in line, or maybe fourth in line in terms of his age. So I had 3 older uncles.
Okay.
So they had kids that were way older than us. But
Wow.
then, they kept on having kids and people kept on being born. So I have an uncle who's younger than me.
That's right. That's right. I know.
So
I have
that
seen
happens.
that before.
Yeah, so that happens too. So we are almost the same age. He's like maybe a few months younger than me.
Now this is not here, of course. This is back in Afghanistan,
Correct.
right?
So we live in this part of the country where it's a border between Pakistan and Afghanistan, and we speak Afghani, which the proper word is Pashto.
Pashto.
So,
Yeah,
so that's what we speak, and we have very traditional tribal culture. So my grandfather was he was the chief of the tribe, and that's where the Khan comes from. Khan basically means the chief of the tribe, just like Genghis Khan and all those others. So that's a title.
So that's the origin of that last name. So it just means that you're the chief of whatever you're in that area.
Correct.
Wow,
so
I didn't know that.
So it's a name and a title. Ours is a title because when you're Khan, so all your kids potentially can become Khan one time.
No way.
So that's what the name comes from, and it's also considered a good name, so people give it to their kids,
right?
So they can give you can. And tell your son Khan, and it's okay to do it there.
Right.
So they don't have to carry in a different name. You can just name them anything you want. So.
Right. And then so growing up there and being on the border with Pakistan, you must have learned how to speak Urdu as well, correct?
Correct.
I'm assuming, I don't know all about Pakistan, but I know that's the main language there, right?
Urdu is the main language. So the part of Pakistan which is close to our village, that used to be part of Afghanistan. So it's a very predominantly Afghan population there. So 100 years ago, that used to be part of Afghanistan. And then with the formation of the different countries and all those things, some pieces were cut off and they become part of Pakistan. But predominantly, most people, they still identify as Afghan in terms of at least their ethnicity.
Right.
So the language. So when I learned Urdu as a kid, it was very. It's a version of Urdu, let's put it this way. And my mom would say pink Urdu. So, so it has a lot of gender bender issues and a lot of because the things in our languages, they have the things have genders, like the chair has a gender, the table has a gender.
Very much similar to what Spanish has. Yes.
Correct.
Yeah.
And so we had those, and that may not be similar in Urdu, so we always made those mistakes. The verbs have genders, so we'll make those mistakes a lot too.
Okay.
So I still make those mistakes, but I'm getting really good at it. So I've been practicing and I've been learning more and more, so to keep up on my skills. So I learned Urdu, and then I learned English as I started from ABC when I was in 6th grade.
Wow.
So we learned English not as a language, we learned English as a subject. So we started with A for apple, B for bus kind of things in 6th grade.
Wow.
And then, so all my education was in Urdu basically in the beginning.
Okay.
So not in English.
Now, was that by design because the teachers were from the Pakistani side, the Pakistan side?
Correct. The teachers were Urdu speaking.
Okay.
And so, we had a very poor literacy rate in Afghanistan. So,
I remember reading those statistics.
So it's very hard to find people who could teach other people. So it was very hard. So for us, it was because Kandahar was 100 miles from our village. Quetta was 70 miles from our village.
Right.
So it was easier to go to Quetta as opposed to going to Kandahar. And plus, those are the days when the war was happening.
Right.
So when we were kids, the war was going on. So it was very hard to go to Afghanistan, proper Afghanistan. So it was easier to go east to go to Pakistan.
And this would have been which war? Because there's been
Afghan war. It's like 1980.
1980 war. Yeah, okay. That's right. Wow. That's a crazy time.
Crazy time.
Yeah. I can only envision what it was like for you and your whole family.
Yeah, it was very hard. And the thing is, in our village, our village is very small. I mean, these are all our cousins and people that are very close to us. And then the war was going, we were very little at that time. And 10,000 refugees were moved into our village area because our area was very distant from the main population. Like we're in the mountains that nobody would believe somebody could live there.
Right.
So, and I think that saved us too in terms of we did not get
conflict.
attacked.
You
were not part of the conflict. But then we had 10,000 refugees moved in there in 80s, and we are farmers, so the land we have, like the apples and stuff like that. I mean, you could not even have access to your own land because there were so many people there, and it became really, really hard. Because there's a lot of war culture going on.
But it amazes me, too, that you were still able to maintain some consistency in your education, because often those services get disrupted when this kind of thing happens, right?
You know, my parents, I think, so I have uncles who did not go to school. And then I had my father who became an engineer. So we have this variation depending upon, like my grandfather was, he was trying people to go to school and he was pushing for people to go to school. But, it depends on with so many kids and everything. My parents were very pro-education. My mom and my dad, they were very pro-education, especially my mom. My mom could not read and write. She could not even read her name. She could
Really?
not sign. So when my sisters were growing up and we were little, and my mom said, like, I want them to be educated. She's like, so this is our words. She like, they kept me from learning even my Quran. She could not even read Quran. So she's like, they kept me from learning my own Quran. I'm not going to let that happen to my kids. So she was very pro-education. So
And she was able to push through that
She would
boundary
push the
because,
bound-
because I guess she would have gotten a lot of resistance from educating your
big
sisters,
time.
right?
Correct. And especially I have two older sisters, and they went through hell to be able to go to school. And they were, even though they were going to our girls' school, and even then it was extremely hard for them to go there. There was so much pressure from their tribe that, you cannot educate them. You cannot send them outside the house. This is wrong. This is going to be shame our family. And it got to the point. So one of my sister got married very early. She was in high school, and so she got married off. And my other sister, she was very young compared to that one, and they were both very good in school. They were really good students. And after marrying off a young daughter, my parents realized that, like, you have to let the girls get a little bit older. They need to be at least 18 or more to get married and things like that. So my other sister, she qualified. She did she did the pre-meds, and she wanted to go to med school. And it was like another war broke off. So it was a big deal.
Now, was she, probably not because I guess of the gender issues at the time, but was she also being told, like, you would make a great doctor or a great person like this when she was growing up?
So no, I think that her main thing was with girls, like, when you get to a certain age, you get married, and then you start a family.
That was the norm.
That was the normal there.
Yeah.
And for her to be able to do so well, and then to qualify for exam to go to med school, I mean, it was insane. It was, everybody was against her except my parents. My parents were like, no. My mom was like, I'm going to go with her because med school was co-ed.
Yeah.
So they're like, she cannot go there. And it doesn't matter if she's covered from head to toe. And that was not good enough. And so
she went there to protect her, for sure.
Yeah, she's like, I'm going to go with her. And my poor sister, I mean, she would go to med school with a gun in her purse to protect herself.
Good God.
So because we getting these threats from the tribe that, they're going to kidnap her, make her an example, and punish her, so people would know not to do this thing.
Wow.
So it was a very hard time for her, and she has done amazingly well, and she survived it. Well,
you always tell me, I've heard you talk about her many times, and that she's
my hero.
Your hero, your mentor, your all these things.
So she was the one who, when I was going through school, and so she said, like, well, you need to go to this pre-med school. And I was like, this was kind of a little bit away, and this was also paramilitary kind of school. And I was like, I don't know if she's like, it's a really good college. I have heard really good things about it. You need to apply there. I was like, and I'm like, little thing, and I was like, what do I know? I was like, I don't think I can get in there. She's like, you just need to apply. So I applied there, and then I was in. So we have 2 years of pre-med, and I did finish 1 year of pre-medical college. And she said, like, well, there's a school in Karachi, and you should apply to this Aga Khan University.
Right.
She said, you should apply there. I said,
Which, for viewership, the Aga Khan is among the biggest universities worldwide.
Yeah.
And I can't remember exactly what the total number of students is, and very well highly rated.
It's
very highly rated.
It's unbelievably good school. And I was like, I would never get in. She's like, you just apply. And I was like, and I was the kind of person that did really well in school, and I was like, I don't want to fail anything.
Right.
And she's like, I promise you, I will not tell anyone that you applied. I said, fine. So I did my MCAT. So I was in the second year of pre-med.
So hold on, the Aga Khan required you to do an MCAT exam, the same one that the ones here.
It's similar, yeah.
Similar,
but
okay.
Yeah, they have physics, chemistry, biology, maths, and English.
It is an entrance exam, but it's not the actual MCAT.
No, it's not actually. It's their MCAT.
Their
it's
MCAT.
Their version of
their
MCAT.
version of the MCAT.
Yeah.
Okay.
So it's not that you just get a good grade and then you go in there. No, you have to do their MCAT. So it's an admission test. You have to do it. So, and I was like, I've not even done 2 years of pre-med. I cannot. She's like, just do it. So you can apply again. Like if you don't get this year,
To apply
then
again
you
the
apply
following.
the next year. So I said, fine. So I did it. And then after, so I passed the test.
On the first time.
So I was like, so I got an interview from Aga Khan. So they're like, well, you still need one more year of college before you come in, but you passed the test. And I did the interview, but I passed the interview process and all those things. So it's like I was waiting. So my med school started on 1st of October.
Wow.
My result for my second year of pre-med came in 2 days before that.
Wow.
And I was like on pins and needles. I was just, once the result came out, I sent them, like fax it to them and ask somebody to take it there personally, like send it to Karachi and then TCS and FedEx and everything I could do. And
every version of transport that you could get.
Like, if you don't get it, you're not going to be sitting in this class.
Cool.
So I finally got in. So it went through and I got in. So.
Wow, that's incredible. And that's a testament to you in terms, several different things. You, your sister, your parents, for really like in all the circumstances you went through, incredible. Like to be able to, and then I think there's an element of, I guess you probably noticed with yourself, you probably didn't think you could do it, but you absolutely clearly could, right?
I was very young. I was 17
when it all happened.
Yeah, when that happened. So like,
you mean you were 17 when you applied to Aga Khan?
I was 17 when I got in.
You're kidding.
So I was like, so I go to school and I'm so naive. I'm like, I'm a nutcase. Like I go there, they call me nut, and I was like, nut. They call me my classmate. They'll call me walnut, and I thought it's a good thing because walnut looks like a brain. And then other people's like, oh no, this is not terms of endearment. They're making fun of you. I was that naive. I did not know if somebody's making fun of me or not. But and like people was like, who are you? I was like, I'm your classmate. They're like, no, you look like 11 years old. And I was like, I am your classmate. I cannot help it if I look that young.
Well, you still look super young, so that gene is still carrying you
I
through.
hope so.
Yeah.
But I think my parents, like, I cannot say enough thanks to them.
Right.
Most kids, when they go through, like at least what I've seen in America, kids go through school, they have to do other things besides med school. Besides schools, they have to work, they have to do this, they have to save money and this. Like, our only job was to study, and that's my parents were like, you don't have to do anything. You just work on your school, and that's all you have to do. My mom and dad, they're both the same way. And when I got into med school, it's a very expensive med school, and luckily I got a scholarship, so that paid for my tuition fee. But my living expenses, and now I moved to Karachi by myself.
It's more expensive,
More expensive.
Yeah.
My dad, he would get his salary, and he will give me half of his salary so I can pay for my living expenses. The other half was for the rest of the family. So I'm so indebted to them. Like, I cannot say enough thank you to them. That like they sacrificed so much for me, and I think that. Whatever I did, like I always feel like they were part of it. They were with me. They were supporting me. And then obviously my sister, she guided me a lot. I mean, those few steps that I took, if I was in any other colleges in pre-med programs, I would not have made that deadline because all the colleges were a few months behind. And that was the only college that was a little bit early. And I got my things on time.
So many things came into fruition, but that for me, at least the way I've always, and you probably feel the same way, I think, is that it truly was meant to be. It truly was.
Like things fall into place.
Exactly.
Like it was supposed to happen this way, but
exactly.
It did happen that way. So it was very, very. I consider myself very lucky to have such supporting parents and siblings.
Don't get it wrong. I think you absolutely deserved everything you got. There's no question about that. But that's amazing, and to know that I'm sure your parents know how much you appreciate that. That I know for certain. So now you're at Aga Khan, and what is it about? It's a 5-year program, right? At what point in time, what do you decide at that moment in time in terms of where you wanted to be, what you wanted to study? Of course, because at some point you end up in Virginia.
Yeah.
So, so I don't know when that happened. So tell us the story.
So I'm in Aga Khan, and so my feeling was I'm going to finish med school here. I'm going to go back to my part of the world, and because there's no doctor there, so I'm going to be one of those doctors who's going to serve the humanity and do the well thing. And my sister's already done with med school, and so she got married the last year of med school, so she's married off. So, and she was like, things here are really, really bad. You will not survive here. There's like, it's not that you want to work here. It's like people will not let you do work here. People will pull you down. They will not let you succeed. And I was going through.
And I think, correct me if I'm wrong, when she's saying not survive, I think she meant physically survive.
Physically.
No,
yeah.
I don't mean like, oh, you won't survive in a career.
Correct.
She meant physically survive.
Physically.
Yeah.
She's like, it's impossible. And so in Aga Khan, most of our teachers were American trained or British trained. So we had all this American training. And so our first dean of Aga Khan was the dean of University of Texas. When he retired from there, he became dean of Aga Khan. So he was chair of the medicine program also, and he was the dean. So when he went back to University of Texas. So we had a lot of this exposure, and I was like, a lot of people were studying they were taking the United States medical licensing exam. They were doing USMLEs at that time. I was like, well, I should do this too. And then my father had an accident. So he had a really bad accident. He was paralyzed from waist below. He was an L1 fracture, so he was paralyzed. And I was in med school, 4th year of med school. And I was like, what am I going to do now? It's like, I have to, and there were these exams that were happening there. I was like, I had to take this exam because they were going to stop conducting those exams in Pakistan. So that was the last time they were going to do it. I was like, this is it. I have to take this exam now. I would never be able to go anywhere because then you have to go to Europe or go to Singapore or some other place to take those exams, and that's extra expenses. The exams are, at that time, they're like $700 exam, and then you have to go somewhere. There's another $2,000 worth of traveling expenses. And I was like,
which things you didn't have and your family didn't have at the time.
And then plus with my father's accident, I was like, I cannot ask them for anything. I have to do whatever I have to do. So most kids in our school, they will finish the med school, they will take the exam. I was like, I cannot wait to finish school. I have to take this exam. So I started preparing for my exam. So I took my 4th year and 5th year of med school. I took both exams and I finished with them.
Wow.
So now I was waiting just to graduate. So by then my father is done. Well, he got out of the hospital. He was in the hospital for 3 months. He started rehab work. He started walk again.
So he was able to regain function.
Again. Yeah.
Okay.
So
good.
again, some function, started walking again. So I got my degree, and the next week I was here, and I had applied for residency programs, and I got into University of Texas.
That's how it happened.
Yeah. So I came here and went to University of Texas.
So this was happening all the exact same time. Your dad's going through recovery. You're writing 2 exams way before everybody else is in your class.
Yep.
So you really didn't have a whole lot of people you could lean on for guidance or counseling at that moment in time. Because I know what that's like. Usually you study together with friends, and no one's doing what you're doing. So.
And plus on the same note, like our teachers were very, they had a really good intention. They're like, we don't want you guys to go anywhere because we built this school here, we built this hospital here. We want you to stay here to be our intern and resident as opposed to hiring someone else. So they were kind of discouraging students to be taking these exams. So I have to study these exams in hiding. I cannot let anyone know that I'm taking this exam because if they find out, they're going to let them know, and that may affect my grade because if they don't like it,
they would try to keep you here in some way. Wow.
So I have to have like a book inside the book. This is how I study. So I had one book on the outside, one book on the inside, and even I could not. My friends and all those things, and they were like, "What's your hurry? Why don't you just? We'll all go together maybe in a few years. What's your hurry?" It's like I don't have time. I have to do this thing. I don't have time.
So what made you decide to go there as opposed to like go to Virginia or Texas at this point in time versus anywhere else? Because
so Texas,
as bright as a person as you are, you probably could have, like, if pushed, you could have gone a lot of places.
So Houston is very, very similar to Karachi.
Really?
Yeah.
Like in terms of
temperature-wise, weather-wise, everything. And there's a really big population of Muslim people, and there's a lot of there are a lot of alumni that were there. It made it easy for me to transition there. When I got there, so that year so I applied with my senior classes, so the applicants with those classes. So I had in that program, we were 7 people in that program that year. All from AKU, all from Aga Khan.
Right.
So there was a big group that I knew them from school. They were my seniors, so I knew them. So it was a lot easier for me to to interact with those people, and we all live in one apartment complex. So it was lots of fun at that time.
Yeah,
that,
it would have been a
you're-
lot of fun.
Yeah,
It would a
so
lot of
you
fun.
know people that you interact with them, and you can.
So all this stuff is happening at the same time at Aga Khan. You're writing all these exams, but at what point in time did you decide that you wanted to go into? Well, I guess your first residency was in
Pete.
pediatrics, right?
Mhm.
So at what point in time did you decide that versus let's
So,
say surgery versus something
yeah.
else? Yeah.
So I had two passions. So I really like orthopedic surgery. I
Okay.
had really good mentors in orthopedic surgery, and I applied a couple of programs, and I had interviews with them too. But I saw their lifestyle, and I was
Mhm.
like, "This is not. I cannot do this thing." They had. So when I talked to the residents there, they had very difficult. I mean, they did not have the reinforcement of those 80 hours or 60 hours rule that USMLE has it, or the ECFMG has those rules. Those rules were not enforced. So you work till you die kind of thing. It's like 100+ hours
Right.
of being on call for
This
several years.
is in Karachi.
No, this is in America.
Oh, this was in the U.S. at the time.
Yes,
Before
yes.
so this is before those rules
Correct.
got implemented. Okay.
Yeah, the rules were there, but they were never implemented. And we had to do the same thing. Like by the time when I was doing my internship, we had the same rules. I work 100 hours a week, each week. So maybe a little bit more than 100 hours. And that they did not enforce the rules that, you can make them work only 80 hours. There was no, like we working, there was keep on working, and that's all we do. I had really good mentors in pediatrics. There were a couple of professors there. They were really good. And I think as a student, my feeling is what excites you, like how you are taught and what inspires you. So I got really inspired by the pediatric team, and then also by the orthopedic surgery. I mean, so I was the only one in my class who got a in our orthopedic surgery.
Wow.
And I had so much fun during that rotation, like tons of fun. But then I was like, I cannot do this lifestyle. Like the residency is hard enough. It's a very hard residency. But I had some interviews there, and I was like, when I talked to the interns there, I was like, oh, that's too hard.
Mm-hmm.
So I was like, I do like pediatrics a lot, and I was like, I can do that too. And I really like that part of my career. So I decided to I just let go of the orthopedic, and I just went for pediatrics.
And then so now you're in pediatrics. And because obviously influenced by a lot of mentors from before. And I agree with you on that statement that a lot of people, and myself included, like the things that you really enjoyed the most when you were doing it is a large part influenced by who is teaching you and how they're engaged with the discipline and how they make you feel motivated and whatnot.
In orthopedics, we were 5 students doing that rotation in that month. So they all paired up. And I was the only one student. I'm the odd number. And so I was working with the chief resident of orthopedics, and all the other 2 students were working with intern and the resident. So we were like one intern, one resident, one chief resident or senior resident. So I was paired up with the senior resident because it's like, well, you know what, they can do things, and I will help you with those things. And the senior resident, he would have his own surgeries planned, like he did like grafting and stuff like that. And so I would be with him, and we will have OR after the OR. And like I did so many surgeries that month, and I just loved it. I mean, there was like, we were on call every 3rd night because that's how rotation was. And I would get all the pre-op patients because these were coming to see him. So he will bring them the day he was on call. So I will see all those patients. And I like 15, 16 patients that I have work with him, and they will do surgeries. We do all the different things. It was, I loved it, but it was just, the work was just so brutal. I mean, I broke my toe in it. It was so hard. Literally, I broke my toe in it. But it was fun. But the inspiration was like, I like pediatrics a lot too, and it's a bit easier to get into, and the lifestyle is a bit easier too. So excellent. I like the peds part.
And so then now you're in pediatrics. At some point, you realize you love. Was it the love of oncology first, or the love of neuro that came in first?
Oh, no. I did not like oncology.
Okay.
I was like, cancer, don't want to deal with it. So cancer was always like a bad thing. It brings a lot of negative feelings and negative emotions. So it's like, I don't want to deal with cancer because I want to deal, I want to like those easygoing kind of things, not necessarily these complicated issues. And I don't want to do cancer at all.
Right.
And that's like, if only thing, cancer oncology is the one I'm not doing. So I decided that. So the first year, my rotation, so MD Anderson is our teaching program, one of the teaching programs. So we rotate through that. So as an intern, I rotate through that twice. 2 months I did there. I really had a very different experience there. So
So it wasn't your initial experience of how you saw cancer.
Correct.
This was very different.
it's very different. So I will give an example. So obviously I was rotating through the pediatric side of it. So we had a school there in the inpatient unit. We had a school. We had teachers. We had social worker. We had people coming in to do. They will do music therapy. They will do all those different things with kids. And there was so much involvement. Like it's not like you're taking care of one child. You're taking care of every needs associated with that. So it was a really eye-opening experience. Like, oh, this is how you can do cancer care too. It's not necessarily chemo and bald kids and things like that. There's more to it that you can do. And we had this big population of Middle Eastern patients coming in. We had a guy who's really good in sarcoma, so he would bring a lot of patients from different countries, and all these teenagers with osteosarcomas and Ewing sarcomas, they would be there. And during internship, I broke my ankle, so I was ice skating, so I was on crutches, and I was doing this rotation with them. They were like, do you have osteosarcoma? I was like, I felt so bad for them. I couldn't say
God.
like I broke my ankle ice skating. I was like, no, I don't have osteosarcoma. I just could not tell them how I broke it because they could not be ice skating. So I was feeling really bad. So that happened. So then second year we have electives. So I decided to do hematology elective for a month.
Okay.
So that went well. And still I was not necessarily buying into oncology. It's like, I don't think so. I want to do oncology. I can do other things, like, infectious disease or something like simpler. That'd be more my
speed.
So finally, the third year, I'm the senior resident, and so I'm doing rotation. And we had somebody who got married, so I was covering them too. And so I was covering two things. One, I was doing one of the resident job, and I was doing the senior resident job too, and I was helping with interns too. So that month go by, and so the program director asked me, it's like, we really loved you being with us and the way you work with us and the team, and maybe you would like to consider oncology as one of the options. I was like, I don't know. It's like, no, just think about it, because we've seen your work and we know how you interact with people and everything, and it'll be a very good thing if you decide to do that.
They saw it as a very natural fit.
Yeah, that's what they think.
Yeah.
I said, yeah, that's like, I enjoyed my month a lot, and I learned a lot, and it was a very good feeling wise. It was a very good thing, and I said, sure, I will. So then I said, like, okay, fine, and they didn't even ask me to go through an interview. I was like, okay. So I accepted their offer. I was like, okay, I'll be your fellow next year.
Wow.
So I decided to do hematology oncology. It's a combined fellowship. So
that's
it's a
right.
Hematology oncology. So
That's
I did
right.
that.
And then how from there did neuro-oncology become the thing?
Yeah. So
I love the face that you just made. Yeah.
So I did not like oncology, so I ended up doing oncology. So then neuro-oncology, I did not want to do either. So I was like, neuro-oncology, it's so much trauma and so much bad outcomes and so much disabilities and all those things. And I don't want to do this thing. And we had a very good neurosurgeon there, a very aggressive neurosurgeon. And his name, Dr. Fred Lang. You probably heard his name.
I've heard the name before.
Yeah. So he was there, and he and the other oncologists did not see eye to eye. So he will operate on a patient with a brain tumor, and the oncology people, they did not see eye to eye. And I was in a fellow, so I have to see every patient, regardless of which team it belongs to. So I have to see. So then I will see the patients. Then I'll call him, like, you know what, I saw your patient, and this is what's going on, and things like that. So I would round with him separately, not with the oncology team. So I would separately round with them. So we did that for a while, and I was like, I don't want to do oncology. These outcomes are very poor. I don't want to do this thing. So I did 1 year of hem-onc, and the second year was my research year. So I started my research year. I was doing this gene expression in frog eggs, and we're doing multi-drug resistant genes. So we're injecting these cDNA into the frog eggs, and we're letting it express it. And the experiment is going bad, bad. And none of the eggs stays. Like, I inject things into it. The next thing you look, they're all broken down. They're all broken eggs the next day in the petri dish. I was like, I don't know what's going on. They were like, you're not doing it right. And I was like, I'm trying my best here. And like, we had to do everything under the microscope. I was like, I'm doing my best here. Like, they're like, no, you're not doing it right. And then we found out the frog had some worm infestation. So their eggs were just poor quality eggs. And I was like, So I had spent like 6 weeks into this experiment. I was very, very tired of it. And so one day I'm leaving, and I'm very upset with the project. I'm leaving, and I see Dr. Lang. And he said, where have you been? I was like, I'm in the lab now. He's like, what are you doing? I was like, I'm working with this project. He was like, I have a lab. Would you like to work with me? So I said, he goes like, I will send you my project, and you think and check it out and see. So he sent me his project, is the things he's working on.
Mm-hmm.
I said, sure, I want to work with you. So I
Well,
switched
anything
labs.
to get out of those frog,
Yes,
those frog
like
eggs.
frog legs and frog eggs. I don't want to deal with them. So I go and start working with him. So he has making this small animal model for a brain tumor. It's a xenograft model.
Okay.
So traditionally, the brain models they use, they have a contraption, like, you had to put them there, all these things. There's the grid system and all this, how you do it. It is a very time-consuming process, and so we were working on a freehand model for the small animal xenograft model. So this project was very neat. So, and I was like, I want to do this thing. So what we did was we had the nude mice, and we'll make a scalp incision, separate the scalp, and we go identify this. So between the different areas on the skull, we identify the place where we want to do a burr hole, and we'll put a tiny burr hole there and put a bolt through it.
Mm-hmm.
And the bolt had a hole in it. So,
Okay.
And we put a stylet in it, so close the hole. And that whole thing will cover it up with the skin again. So then the animal has a bolt. It's like an axis, it's like an EVD, but under the skin. It's like almost like an Omaya kind of thing.
Right.
So
we're talking about basically a tube that's inside the animal skull.
Correct.
And it's now healed around the tube.
Correct.
And
the tube is
you can now
actually
apply things intracranially if you need to. Into
so
the
it's
brain.
actually a bolt. We had made a hole in it.
Mm-hmm.
So you screw it in. So very hand-free. I mean, this is very easy. So we did this. This model was so, and then we'll make a needle to see how deep we want to go. I make marking on the needle how far we're going to go in there. So you can go in there and you just inject whatever you want to inject. And Fred was working on P53 and GBM at that time. So this project was going on. So he was working on those things. So I created this model with him, and then then we wanted to take away all the variables from the experiments. For example, like, when you get a cell culture made and you want to inject it, and if you're doing injection into the animal, so you start with in the morning, by the time you get to the 30th animal, so these cells have been sitting here for a long period of time, so the cells may not be exactly the same thing as it was in the beginning of it. So we want to take this variable out. So I found this pump. It's this IV pump, but I used it upside down, so it doesn't have to be standing up. So it's on the pole. We put it on on a small brick, and then we put the animals underneath it, and then we put all the syringes there. So I will fill the syringes up, 10 of them or 15 of them, and I will inject all of them at the same time. So I can do the whole day work in half an hour.
Okay.
And then the cells would be all the same and all those things. And that project took off. It was really good. A lot of people approached me they had chemicals they wanted to test for brain tumors. So they would give us chemicals. Can you please test this in your brain tumor model? Can you test this thing?
See if this would work or not.
This would work or not. So all these PDFGR molecules, everything, we got all those things. We started doing those things. And then there was another scientist, Juan Foyo. He was working on adenovirus to treat the brain tumors with adenovirus. So, and this is a replication-competent adenovirus.
Okay.
So the idea was, and this virus can replicate only in cancer cells and not in the normal brain tissue. So he took some of the genes out from there, which will, and the genes that the virus use, they are already active in the tumor cells, so they're not in the normal cells. And the virus can take those pathways and keep going and keep replicating only in the tumor cells.
Okay. That's interesting. So it uses the replication machinery only of the tumor cells.
Correct.
That's interesting.
Yeah. So
interesting idea.
Yeah. So the tumor cells have things that make them replicate, and it's like a stop. They have things that they don't have any brakes on it. For the virus to replicate in the normal cells, they have to take those breaks off.
Mm-hmm.
So if you take that break part off from the virus,
Mm-hmm.
it goes into the normal cells. It cannot take the breaks off because it does not have that.
There's nothing to
machine.
use.
Yeah. So, but in the tumor cells, it does not need to do that. Tumor cells will give its own the breaks are off already. So
Right.
it just keeps replicating, and then they disperse into different cells, and they just almost like burst from one cell to another cells and infect the whole brain tumor. So
Wow.
so I did those experiments with them. So I did all the preclinical work for the adenovirus.
And so at this point now, you've created a great model, you've got a great experiment, you got great results, and then at this, you said to yourself, "I do want to do brains." Or
Yes, I was like, I want to do brains. I was like, this is so much fun that it's challenging. There's so much more we can do
Right.
for it, and there's so much more that needs to be done for it. I was like, this is when I was like, I want to do neuro-oncology. So so I'm doing these research, and the virus it became very popular. It's actually got approved by FDA to be used, and this is what they use in MD Anderson now. So I did all the preclinical work, all the animal experiments. I did all of those things for them, and then I was like, you know what? And then when I finished with my 2 years of research, they said, would you like to stay an extra year in neuro-oncology? And when you're done, then you can be a neuro-oncologist also. So you can just do brain tumors. I said, yeah, that sounds good. I was like, I don't think I can do leukemia anymore. I was like, yes, I would like to do a neuro-oncology. So then I stayed an extra year to do neuro-oncology.
Wow. So let's get this right now. So at this point in time now, you finish your neuro-oncology fellowship. So you are now a certified pediatrician, hematologist and oncologist,
Yep.
and neuro-oncologist. So triple boarded.
Yeah.
That's crazy.
Yeah.
And all in a strategy of no intention of going that way.
Correct.
You hated every single one of them except for pediatrics, which you liked.
Yes.
And then somehow went from hating to loving, and then did the same thing again.
Yeah. Again and again. It's just
so now I know how to get you somewhere. Make sure that you hate it up front, and then we find a way to tweak it.
Yes. And I think I think that you see an aspect of that career, or you see aspect of it that actually talks to you or speaks to you, and then you're like, oh, you know what, this is what I want to do. It's not just all the other things that stops me from doing it, but this thing is so much intriguing that I would like to continue with this thing.
And now you've been in the field now for how long now? Oh,
so this is like 7 years in training. So then they're like, so then there's like, well, my visa was only for 7 years, correct? It's a J1 visa, 7 years. Yeah. It's like, you know what? We're done training you. You need to go find a job. You need to do something. And this is how I went to Virginia,
right? Because
then I have to find a job to do all this thing. So that's how I from hem-onc and neuro-oncology, and this is how it.
And you worked in Virginia for how long?
Almost 8-9 years.
8-9 years there first, and then got recruited to Aurora in Milwaukee, and you were there for about the same.
Yeah. 6-7 years.
6-7 years. And then from there, now here into Arlington Heights, Chicago. And you were still able to maintain that other part of your life as well, because I remember you telling me in Virginia, you owned a farm.
Yes,
right?
Yes.
Yeah.
So I think what happened was in Virginia, Virginia is very relatively cost-effective state. It's not very, very expensive. And
I guess the part of Virginia that's not close to D.C.
Correct. It's not close. It's actually Richmond, Virginia. So it's not very close to D.C., but it's a very good place. It's very good. And Virginia has 4 seasons, so it has 3 months of each weather. I mean, like the seasons, like summer, winter, everything.
And this would be the first time you would have been exposed to that kind of terrain, right? Because you said, Karachi was very similar to what Houston was like. And I wouldn't have imagined that Quetta and your area.
Quetta is very cold. Quetta and our village is more than a mile high.
Okay.
So it's very cold, very rugged, very dry.
And the terrain doesn't really have a whole lot of vegetation,
Correct.
I wouldn't
think.
The terrain
is very barren mountains. Tall mountains, barren.
Barren, nothing much there.
Nothing much. Just you have to have a spring somewhere to grow something. Otherwise, and we didn't have electricity growing up.
That's right.
So,
I remember you telling me that. Yeah.
So it was very, very limited resources at that time.
Wow.
But Virginia, so the thing
was...
So
now you're in Virginia, which is much more lush and everything
else.
Lush,
and so there's so many stories with Virginia. So, so Virginia, so my first job as an attending.
Yep.
I get some money, like a sign-up bonus and stuff like that. And I buy myself Prada shoes.
Why not?
Yeah. So because the devil wears Prada,
The
so I
devil.
so I was like, I need Prada shoes. Like I don't know what was so special about it. So and in Virginia, so when I went there, the program, they wanted 3 people.
Uh-huh.
So they wanted someone to do adult neuro-oncology. They wanted someone to do pediatric neuro-oncology. They wanted someone to help them in hem-onc also.
Okay.
So they got me.
They got you for everything.
They got me for everything. So they said, like, well, we don't have any of these programs. In Virginia, there was only one neuro-oncologist, and that was in Charlottesville. And
In the whole
it.
state,
In
we're
the
talking
whole
about.
state.
That's a funny thing because like, I say that because that's not unheard of in this country.
Yeah.
Neuro-oncology, there are very few people around. Like outside of Chicago here, is there anybody? Like out in the state of Illinois, there might be there might be one. I don't know.
I don't think so. I don't
Is there
think
someone in Springfield? I don't know.
I don't think so.
There's nobody else.
Yeah.
In Wisconsin, there are how many?
Wisconsin, there are like 1, 2, 3 people.
For the whole state,
For the
right?
whole
Like,
state.
so Virginia, at this point in time, you're
you're
number 2 now.
I was number 2. And I was number 2, and then I was going to start a program for adult neuro-oncology. I'm going to start a program for pediatric neuro-oncology. In the meantime, because there's no patient right now, so I will help with hem-onc also and round and once a week, like every 6 weeks, I will be the inpatient attending for the hem-onc team also. And that include bone marrow transplant also. So I will do those things too.
Why not?
Why not? Correct. So, so I got my new Prada shoes. So I go, and I'm covering the hem-onc unit. And so we had this young kid being admitted overnight with sickle cell crisis.
Oh.
So I'm covering the hematology service also. So I go there, and the kid is laying in bed, and the mom is sitting next to him. They're from Nigeria. And so I was asking the kid, so how are you doing? And he goes like, Uchi, Uchi. So no, he said like Gucci, Gucci. I was like, Gucci? I was like, this is not Gucci. This is Prada. So...
Oh,
yeah.
And how old was the kid?
The kid is 6 years old. And I'm like, I look at his mom. I was like, and my nurse practitioner, I was like, this is 6-year-old. How does he know brands? I like, how can he know Gucci and Prada and all those things? How does he know Gucci? I mean, and I look at her, she's like, I don't know. And I was like, the kids nowadays, so we're talking about like the kids nowadays, they're so precautious. They know brands and stuff like that.
Right.
And I asked his mom, I was like, how does he know Gucci?
Uh-huh.
And she looks at me and she rolls her eyes. She's like, he is not saying Gucci. He's saying Uchi, Uchi. He had an IV in his arm, so it's instead of Ouchie, it was Uchi, Uchi.
That was what he was saying.
I was
Uchi,
like, oh
Uchi.
my God. I was like, I'm so embarrassed. I look around. My nurse practitioner, she had her hands on her eyes. She's laughing so hard. I was like, I'm not wearing Prada shoes anymore. I was like, this is it. So this is it was lots of fun. I mean, the Virginia was good, but the only thing was because I was doing 2 programs, I was helping out with.
That would have been a lot.
I had no time for anything.
No.
And at that time, I wanted to have my farm. I had a chance to buy a piece of land, which was very reasonably priced. It was like 30 acres of land. I was like, I can do a lot with this thing. And I could invite my family to come. I could invite my brothers and my cousins. They all can come. I can give them a piece of land. They can make a house there. They can live there and all those things. So I was thinking about all those things. So I was like, okay, I'm going to start a farm here. And I have... So
I'm laughing because I know what's about to say. But go on.
So this is the it's just outside the downtown. It's like 20 minutes from the hospital. It's not too far from the hospital either. It's very close to it. And I was like, okay, I can do it. So I send my new address to my friends, and it's a 101 Dude Ranch Road. So I start getting these calls from my friends like, oh, so it's true. So I was like, what is true? They're like, when you left Texas, we were told that you went to Virginia to be a goat farmer. I was like, I'm not a goat farmer. I'm still a doctor. They're like, we were told you give up medicine. You're a goat farmer. I was like, no, I'm still I said, well, that's a very good idea, though. They thought like a dude ranch. I'm living in a ranch. I was like, no, it's the name of the road. But so it's a really good idea. So this, I like, I'm going to get some goats. I was like, I'm going to have my goat farm. So that's how I ended up with a goat farm there.
Yeah, and you ended up with how many goats? Was 6? 5? 5? Yeah. Dwarf goats, right?
Yeah, they were miniature goats.
Yeah.
So I did not. So that's another thing. You know, I want things, but I want them pretty. so I want the miniature goats.
Yeah.
I want them to be fancy.
Yeah.
And when Gretchen, my goat, when she became an adult, and I was like, you know what, I'm going to breed her. So she's going to go on a blind date. And everybody in my team knew about the goats. They would come and they would play with them and all those things. So one day I'm sitting with my nurse practitioner. I was like, I said, Gretchen is going on a blind date. She's like, what? I was like, yes. She's like, is Gretchen old enough to go on a blind date? I was like, yeah, she is. I mean, this is, what can I say? And she was like, what are you going to do? I mean, this is a big step. I was like, we're talking about like they're people. So I was like, yeah, it is a big step. She's like, oh, well, how would you feel like being a granddad? I was like, I don't know. I was like, we'll see. And we have medical students sitting next. She's like, is Gretchen your daughter?
And you're like, of sorts.
Yeah. And my nurse, she's like, what do you think? Like, he's going to be breeding out his daughter. She's like, what is Gretchen? He's a goat. So, all my the team, they knew Gretchen and Gandalf, and so they will do things. And Gretchen did go, and so they were very. They were very small, tiny goats, and very pretty, and very well taken care of. And when Angus came to visit Gretchen,
who was not your goat?
Yeah, Angus was a borrowed goat. He was paid for services. So, and my friends, they were like, we cannot believe you're going to make Gretchen marry him. And I was like, this is animal. These are like, but they're like, your Gretchen is so sophisticated. She's like those girls who sip champagne with the pinky up. And I was like, yeah, but
whatever, here we are.
Whatever, we are. Gretchen ended up with 3 kids. That's like, she did not mind him that bad. So,
oh boy, that's funny. That's really, really funny. So now I think I'm going to pivot because eventually you end up finding your way to Milwaukee, and that's where we met.
Correct.
And then we've been very blessed to kind of stick together as a team and move on to work here in Arlington Heights with the IMG team, and working with Dr. Sam and everybody. And what I want you to kind of guide people through is like, I probably should have done this at the beginning for the people to understand. Neuro-oncology means that you deal with people who have brain tumors of all types.
Correct.
Oncology would imply cancer, but you also deal with benign brain tumors as well. And they can come in all various shapes and sizes with all various types of prognosis. Correct. And I wouldn't be incorrect, you correct me, to say that the majority of cases traditionally, when anyone was diagnosed with a malignant brain tumor, it was never a good thing.
Correct.
And since I've known you, that has massively changed. Would you agree?
Yeah, I agree. I think things have changed. I think the technology has changed. And so one of the things that when I was doing these programs, one of the things I was working on, and I will explain the situation back in Virginia, and this is why I was so excited coming to Milwaukee. So in Virginia, our hospital was made in stages. So there was 3 hospitals. They were all connected through different levels, and parking was on one side of those hospitals. So the person would come in, the radiation team was somewhere else, the neuro-oncology team or the oncology team was somewhere else, the neurosurgery team was somewhere else. So you have to go to one building, and the 7th floor of that building was a walkway to connect with the 2nd floor, another building, and the 7th floor of that building connected to the 2nd floor. So there's all weird things that they're all made in steps. And people will be lost all the time. Which building, which level, how do we connect with the other one? So my neurosurgery colleague there, Bill Broaddus, is a really good guy. And one of the radiation oncology team, we said, like, this is not fair to our patient. Like, we were the 3 people, and we started the neuro-oncology thing together. It's like, we need to have one place that patients
where they can all be seen. Yeah,
they can be seen. I said, this is not fair for them to go 3 different places. And I was like, I'm lost here. I'm the doctor. I get lost in these corridors. So we started doing things in like one place that we all sit down together, and then we'll see patients together. And that's where the whole thing for me was this, like, how to provide good care to our patient. And how do we provide it the better way? I think, yes, seeing different people was hard for them, and then knowing what they're going to tell you. Those were the days, like the electronic records were not as good. You had to dictate things, and things would come up maybe a day or 2 later in there. So you don't, like, if I see a patient, I would have to ask the patient, like, what did the surgeon tell you? What are they going to do? And like those, there's a lot of delay in the communication there too. So we started doing this thing. So when I came to, so I got burned out. So that's what happened. So I've been doing this thing. So I'm on call for pediatric neuro-oncology. I'm on call for adult neuro-oncology. And then once every 6 weeks, I cover 1 week of the hem-onc and bone marrow transplant also.
Mm-hmm.
And I'm the only one doing it.
Mm-hmm.
So I'm on call 24/7, 12 months a year,
Mm-hmm.
every weekend,
It's exhausting.
For 5 years, I did not have a day off.
Yeah.
I was like, I cannot do this. I mean, this is just too much. I mean, my organic garden, I mean, I didn't see the poor garden for weeks. And by the time I would get there, the weed would be up to my knees. I mean, that was like, it was insane. I could not enjoy what I was doing. I could not enjoy my land. I could not enjoy my farms or anything. And that's when I was like, I cannot do this. This is not safe for me to do it. And I think that's where the quality of life comes in. Like you need to have, the quality of life not only applies to patient, it applies to providers too.
100% it does. I completely agree with you.
So it's like, this is not safe for me. This is my beginning of my career already burning out.
Yeah.
It's like, I'm not going to be able to carry on this thing.
But because it also affects how you're treating people, right? Like if you're not yourself healthy, it's very difficult to, and we've done it. You've worked sick. I've worked sick. We've done this before because we have to.
Yeah.
There's people that need the care immediately, but you have to have mechanisms and things put in place to protect us so that we are able to come in the next day at full strength, not the other way around. And that involves all the things that you're talking about, like having those things in your quality of life that kind of give you joy and give you peace and give you mental serenity and all the things you need, right?
Yeah. You need a downtime.
Exercise, whatever.
Yeah, you need a time when your pager is off, you're not on call.
Yeah.
You need that peace of mind. I could not sleep well for years because my phone would be sitting next to my head just in case I don't miss a call. And I was the only neuro-oncologist in the whole city.
Yeah.
So it was really hard. So things were going on. So when George and I met George in one of the SNO meetings, the Society of Neuro-Oncology. He's like, we're looking for a person too. I was like, I'm looking for a job. So he's like, why don't you come and see us and we can talk about it.
Shout out to Dr. George Babustik, who is the other co-chair of our team, but he's also a wonderful man.
Wonderful person. So I said, sure. So this is how I came to Milwaukee. And then, so my thing was, I had started something in Virginia, which is like the tumor board or this combined clinic, the MDC clinic. And when I saw that how well it was established and running in Milwaukee, and I just loved it. I was like, this is what I've been working on. It was really hard to do it. Every subspecialty, they are run by RVUs. So for somebody to say, like, you have 10 neuro-oncology patients a day and the radiation oncologist is going to leave his clinic to come to you, it took us a lot of work and dedication at that time in Virginia to do that, for somebody to give up their clinic to see patients in a neurosurgery clinic. So there's sacrifice that was made, and it was very hard things to do. So when I saw that how things were running in Milwaukee, and the multidisciplinary clinic, and then and then the review and all those things, and this is what we used to do. And I was like, I love this thing because this is what I wanted to do it for so long, and you guys are doing it so well. I was like it makes sense to me. The other thing was, that I wanted to have a partner. Like I did not want to work by myself because I wanted to take time off. I wanted to be off on a weekend. I wanted to be not on call 24/7. And George being there, so that was like, what, we can alternate now. So I have somebody who I can trust his judgment, and we can share calls, and we can alternate weeks and weekends and stuff like that.
Yep.
And that's why I was so excited to be part of that team.
Yeah.
And plus, so you were there. There's a pride in taking care of patient.
Yes.
It's like, it's not just, I have to do this thing because I get paid to do it. No, I do this thing because it gives me joy to help someone.
100%.
And that's what
100%.
I saw in our team in Milwaukee, that with Kassam. I mean,
Yeah.
Kassam's amazing in that sense, how much he invests into patients and taking care of them. And I saw that, I wanted someone that I can be proud of to be a partner with. It's not just me, it's a team. And I don't want to be the only one working in that team.
Yeah.
I want everybody is so good. Everybody is exceptionally good.
You want your team to be as equally invested in everything as you are. And that's what I think we're blessed with as a team, that since we met since before and now, everyone we've recruited into the team has been exactly the same.
Yeah.
Everyone is full, we're all together, but we all want to protect each other. If one of us has to get away, you can. And so, but the patients still get all the care they need.
Yeah, yeah. And I think that's the important thing is, quality of care, what quality of care you provide. am I satisfied with the quality of care we provide to our patient or not? They're like,
Mm-hmm.
we have to have this conversation within ourselves. Like, can I leave my patient to this person or not? Can I
Yeah.
do this? And you have to be very, very it's not that I hoard my patient. Is at the same time, I don't want anything to happen to them. I mean,
Correct.
they have one bad diagnosis. I don't want something to happen to my patient just because
They already have it
somebody
hard
made
enough.
Correct.
Right. Yeah.
And my father passed away years ago from a medical mistake. I mean, he survived the accident. He died because somebody gave him wrong medicine or too much of a pain medication, and he died from that. And I was like, I want to make sure that the person who's going to take care of my patient when I'm not there, I can trust them with my life.
Yeah.
And like George and Kassam and you, and now with Alex and everyone else, I trust those people because they can do the things that I would do for my patient.
Right.
And they will go beyond to help them out.
Right.
So I think that was the importance of the care team, that, we have a team now. It's not just everything on me. I have other people to share this responsibility that we can help those patients.
The whole region is blessed to have you here. There's no question about that.
You.
That I know. And I know for me as a team member, we love having you here as well for so many different reasons. One, you provide amazing care. We know that no matter what level of distress that a person is coming in with, because most people may not understand, most of the people who you end up seeing are people who are really given a bad news on that day. And you are able to make them feel super comfortable and super appreciative and both accepting of what's happening, but also hopeful that, that what they're going to get is still appropriate. Like, not to say that we do a bad job, but you do an amazing one.
Thank you.
Overall, for sure.
I think part of the thing is, like, as I said, like we had this conversation before, like, I don't specialize in tumor. I don't specialize in a disease. I want to help the people who are going through those conditions, so that I can help them out, and I can be part of that journey with them, and take it away from them somehow, and make it easy on them, the bad news they got, and give them some hope also. And I don't sugarcoat things, but at the same time, I don't take away their hope either, because there's always that hope that something may work, and why not try it and see what comes out of it.
And you deal with so much of the emotional roller coaster of it for the patient. I remember one of our younger patients who unfortunately recently passed away. There was days that, because of the treatment, and it was just the nature of it, what it wasn't ideal for anything, but for him, because of his rare condition, he would come in angry, angry on some days. But you would handle that like it was a piece of wind. Like, he would, express it, and then it was just like, it's okay. I get it.
Then he will apologize in the end.
Yeah, I know. And it was a large part is because your demeanor and the way you're able to handle it. So, that's a testament to you and to so many things.
Thank you.
And which is why it's shocking to me to hear the entire story of how you got to there, is that you had no interest in doing any of this to start with.
I was going to be a hand model or a farmer or something.
Yeah, still trying to look at the Gucci's and the Pradas. Yeah, that's right.
But I think, the older we get, life has a way of teaching us things. And I think learning those lessons, and I see people driving badly on streets, and I was like, well, maybe they're having a bad day now.
Yeah.
Maybe maybe this is one of my patient, or this is going to be my patient. Like, I see them, it's like I feel bad for them, not necessarily be mad at them, but actually bad for them. It's like, you know what, you may be going through something. And I think I knew this from working with patients, and then seeing it, your experience, Dr. Kassam's experience, and everybody else's experience. When we share that with each other, when we get to know life is different, and it's there's so many things that happens to us, and that's another thing. I think we see patient or people in a way, the way we see them, but we don't know the whole picture. Like, there may be something going on with this person, we just don't know it.
Right.
And the grass may not be greener on the other side, and this person may be going through something really, really big.
Right.
And they just, and I always give the other people the benefit of the doubt. You know what? In life, nobody has a perfect life, and everybody has something going on in their life that can be hard.
For sure.
And
so, in an effort to kind of round everything out in our conversation, there's lots of misconceptions that we see in medicine and things like that, and your discipline being not exempt from all those things. If you were now have the moment to tell your population of people, of either potential patients, future patients, current patients, any piece of advice that you can, about, either how they would A, access you, but B, like what they should do or whatnot, what would you say?
The thing is, we don't have any screening tests for brain tumors yet.
Mm-hmm.
So I think that's something I cannot say, like, you need to do. And we don't have necessarily know all the risk factors why would somebody get a brain tumor. Like, it's not like, you smoke, you get a lung cancer, so it's a bad thing for you, and I can tell you what to do. It's not like that. I think having this open mind to it, that things are going to happen to us someday, but there are things we can do. I think nothing is it's not done deal. There's things we can do. There are things we can find out. And the other thing that my experience is, there's no early diagnosis for brain tumor. We cannot, like, I see patients that, with this, the tumor is 4 centimeter now. What if I had done an MRI 6 months ago? You could have found it when it was 2, and you could taken it out and all those things. There's no early diagnosis.
Right.
Things are the way they are. We just have to deal with the situation. We have to make the best of what's in front of us, not worrying about it. What if I could have done this? What if I could have done this? I think that's something people need to work on it. I think we go through those
Everyone
cycles,
does at some point, yeah.
But the making decision at that time, my job here is I give people all the options. And explain each option to that person so they can make informed decision. Informed decision is not what I want them to do. And it's not like what I want you to do is this is what you have to do it. You need to know all the other options, and then you make a decision. I don't want people to make decision because of fear or surgery. No way, I'm not going to do surgery. Or radiation. No way, I'm not going to do. I want them to know what that is and then make a decision. I don't want them to make the decision prematurely and not get a benefit from an intervention. But the other thing is, when we talk about prognosis to our patients, we say like something is, for example, 2 years, 5 years, average survival and things like that. Well, this is not good enough. I say that I agree with you, it's not good enough. But in 2 years or 3 years or 4 years, what if there's more technology comes up? If you're here,
and we've seen it happen live,
if you're here at that time, 5 years from now, there's something new coming up. And if you're here because you did this thing right now, and then this thing will be available to you. You can use it at that time, and God knows how much. Like when it's time to die, it's time to die. I mean, I could not save my parents. I could not save somebody else either. So when it's our time to go, it's our time to go. But there are things that we can do. I think we don't have to give up so early. I think there's always a hope. There's always something we can do. And I do a lot of palliative care. I do hospice care and all those things. And what I tell them is, I'm not giving up on you. I'm not saying, we're just changing our focus. There's still things we can do. Well, what can that be? Well, having a peaceful end of life is a good thing. People could have, I could have a very bad end of life, but if I'm going to die anyway, I would rather that be a peaceful, my dying process to be peaceful.
Yeah.
And I want my loved one to be around me. I want my loved one to be at peace too with all the decision I have made or they made for me. I mean, this is, in itself, is a good achievement or a big achievement when you say, like, I did everything I could and I'm okay with my decisions. Now it's not up to me. Well, I'm very spiritual, so it's up to God that I'm going to die now. But I'm at peace with this thing. I'm not in pain. I'm not suffering from anything. And it's my time to go, and I might say goodbye to my loved one. I think everybody deserves that ending. Everybody needs that dignity. When they die, they need to die with dignity. They don't need to be struggling with things. They don't need to be pulled and pushed apart and all those things. They need to be at peace at that time.
Yeah. And you've always been able to connect on such a great level with many of these people at that moment in time that, you got us involved in moments that at times we wouldn't know that we would be the right time, that we would have to come in and do something, help, because even though they have declared that, there's nothing else we're going to be able to do for this, some aspect of their quality of life is tremendously affected that we can actually help with.
Yeah.
And so it's a very, how do I put it? Not talked about thing, you know what I mean? But it's something that is undervalued when it should be much more valued.
Correct. Yeah. My personal thing is, I think people don't pay enough attention to their social workers.
Yeah.
I think they're undervalued. People don't pay enough attention to palliative care, hospice care providers. They can be tremendous help. Nobody is going to live here forever, but you need to have that process that people can say this thing. I think death is not something we want, but death is something which is going to happen. And I think we need to be able to prepare ourselves for that. When that happens, be prepared for those things. I think it's very, very unfortunate. We see survival as an outcome, and we don't see, dying with dignity could be an equally good outcome. When we talk about trials and stuff like that, did I do a good job for this patient? And I think it's not just did this patient lived well or not. I think that needs to be taken into account. Like, how well my patients are doing, not just living. Are they doing other things they want to do, and are they achieving those goals too or not?
Well, I couldn't. You said it perfectly. I couldn't say it any better than that. I know that it's Ramadan for you right now, and you're probably extremely hungry because the sun.
I forgot about that altogether.
The sun has gone down. Iftar is probably already hit, so it's time for. I got to get you fed. But the one last thing I want to ask you about is something that I want as a message for the people to know.
Yeah.
If they happen to get diagnosed with something like a brain tumor or whatnot, because I'd like them to know, what would you tell them to be their first steps?
Yeah. I think, so brain tumor, any kind of tumor, comes with a lot of anxiety.
Kind of tumor, that's right.
It comes with a lot of anxiety.
Yeah.
I think instead of Googling things, I think trying to reach, if somebody has a brain tumor and they need our help, anything, call us. Call us right away, and then we can help you. We take turns to be on call. I see patients on the weekend. I see patients after hours. I see patients all the time. And so do my partners, and they see patients all the time. So we take turns to be on call. We don't want our patients to suffer unnecessarily. If there are things we can do to take away, like I had a patient who had a benign meningioma, was diagnosed by someone, and the medical oncologist called me. I called that patient before the weekend. I was like, listen, this is a benign tumor. We will see you as soon as you want us to see you, but you don't need to worry about this thing. Have a good weekend. You deserve a good weekend. I think people need to, and obviously there are times when things are sensitive, you don't know how significant this is. It is the best to talk to someone about it. Like, if they want to talk to us about it, we're on call all the time. So we have one person on call, and we can help them. We can do whatever needs to be done. If something is urgent, we'll tell you this is urgent. Come to the emergency room, or this is an emergent situation, or this can wait for another 2 or 3 days, and we'll see you at that time. I think people need to take the first step to initiate that conversation instead of worrying about it. Let us tell you, do you need to worry about it or not?
Yeah.
And I think that's something. The second thing I will say is there's another thing. It's before somebody has a tumor. We have a life, and there are things we can do for our life. I think there's nothing special about the brain that we can do or that can be done to protect the brain. We have to do the normal healthy stuff, healthy diet, healthy sleep, healthy activities. That applies to the body, that applies to the brain too. So if somebody wants to know how can I keep my brain active and alive and well, sleep, eat well, and exercise. And those are the 3 major things that we have, scientists have identified them. People have data on it that helps with the brain. It helps to increase the vitality of the brain and keeps you younger longer. And it applies to the rest of the body also. So if somebody wants to do something, I cannot prevent cancer, but you know what? Can I do other things to stay well? Yeah, there are things we can do.
Well, that's great. Well, Asad, I know that you and I could sit and talk forever about this stuff. And so what that tells me is that I got to bring you back.
Okay.
No question. We'll have more fun. We'll play some games here too.
Sure.
And you'll have a great time. But cannot thank you enough for being here.
Thank you. Thank you for having me.
This is awesome.
Oh, thank you.
Well, that wraps up today's episode of the Intent Medical Group podcast. Thank you for tuning in. If you enjoyed the episode, don't forget to subscribe, share it with a friend, and leave us with a review. Until next time, take care.